Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical PDF for internal medicine. Today we'll be talking about the internal medicine, reproductive, and OBGYN section. So, let us begin. And this will probably be 2 videos as far as I'm aware. We're on page 180 right now, and we'll probably have a little bit more than 30 pages to complete it, so we'll probably do this in 2 parts, maybe each of them probably being about an hour and a half each, I would assume. But anyways, let's begin. And because this is on the reproductive chapter, I guess I should give you a warning, I guess, if it becomes a bit too explicit for certain audiences. I don't suspect it's going to become too much of an issue, but obviously it's talking about the reproductive system, so I guess in theory it could be a bit more suggestive in principle. But with that out of the way, I'm assuming it's going to be relatively tame and clinical. I would assume. So let's begin. Penile/testicular disorders. Hypospadias. Urethral meatus opens on the underside of the penis, ventral aspect. Epispadias. Urethral meatus opens on the top of the penis, dorsal aspect. Neither of those sound particularly charming. Okay. Phimosis. Cannot retract the prepuce foreskin. In other words, cannot pull it back to expose the glands. Paraphimosis. Cannot reduce the prepuce. In other words, once it's retracted, one cannot replace it back over the glands. Just remember that paraphimosis is the bad one, emergency situation. Okay, so if you accidentally, this is kind of gross, but like if it gets stuck, if it's retracted and it can't be brought back to its original position, go to the emergency room. That's an emergency situation, I should say. Right. Anyway, cryptorchidism, undescended testes, increased risk for infertility, elevated temperature within the abdomen means decreased spermatogenesis, increased risk of testicular carcinoma. USMLE wants no treatment prior to the age 6 months, but after 6 months, you perform an orchidopexy. What about testicular torsion? Acutely painful testes. Medical emergency can lead to ischemia and loss of testes. Can be caused by abnormality of the gubernaculum, which is a ligamentous cord that anchors the testes within the scrotum. This leads to a bell clapper deformity, where improper anchoring leading to increased risk of rotation. Yeah, the names are a little bit just kind of okay, I guess. It's kind of very vivid descriptions. You know. Negative Pren sign, which is failure of relief of pain upon lifting of the scrotum. Apparently, this is an unreliable test in real life, but NBME vignettes can still mention it. In contrast, a positive Pren sign, relief of pain upon lifting the scrotum, is more indicative of epididymitis. So basically, if you're in this sort of testicular pain, or scrotal pain, you could say, and you lift them up, and if it's relieved, that's positive Pren sign. That probably means it might be epididymitis. But if it doesn't relieve, it's still painful, then that's called negative Pren sign. That might indicate testicular torsion, perhaps. Negative cremasteric reflex, which is a failure of the scrotal skin to retract upon palpation of the medial thigh. In contrast, a positive cremasteric reflex, scrotal skin retracts, is more indicative of epididymitis. Normally, the inner thigh is stroked, the cremaster muscle contracts and pulls on the ipsilateral testes. In torsion, the twisted spermatic cord can impair the nerve fibers responsible for triggering the reflex. The USMLE wants the Doppler ultrasonography as the next best step, followed by surgery. Epididymitis. Inflammation/infection of the epididymis. Positive Pren sign, as I said before, and positive cremasteric reflex. Chlamydia and gonorrhea are the most common causes in males less than the age of 35, but over 35, E. coli is the most common. USMLE will not play games where they give you a borderline case and force you to guess. They will either be a 25 to 45-year-old male. You'll either be giving a 25 or a 45-year-old male. This goes for prostatitis, the same organisms. Again, like chlamydia, gonorrhea, E. coli. Again, what is it going to be? It's dependent on the age, basically, in terms of how these present on vignettes. This is an NBME question of a 45-year-old where the answer is E. coli and chlamydia would be wrong. Torsion of appendix testes. not the same as torsion of the testes. It's torsion of appendix testes. Asked on the 2CK form, question will tell you there's a kid with a painful testis plus superior pole is blue. There's an intact cremasteric reflex. Regular torsion, it's not intact. Yeah, okay, fair. Blue dot sign, blue superior pole of testis. That sounds very disconcerting. Not my opinion. If you think it's a nitpicky or weird, take it up with MVME and exam. Okay. Peyronie's disease. Curvature of the deformity of the penis caused by fibrous plaque with tunica albuginea does not have to be treated unless causing functional impairment. So it's a severe curvature deformity, basically, caused by fibrous plaque within tunica albuginea. Orchitis. Orchitis, inflammation/infection of the testes. Mumps is a high-yield cause in unvaccinated/immigrants, sometimes implies unvaccinated. Yeah, the reason why is it unvaccinated plus immigrants? Well, because the immigrants are not being vaccinated. That's the reason why. The vaccination regimens in other countries are not the same as the United States, and so you might have an immigrant from a developing country, i.e. Latin America, Sub-Saharan Africa, for that matter, really anywhere that's outside the Western world, and they might have a different vaccine regimen or what they got in terms of vaccinations, or maybe they don't have any might And as a consequence, they're going to might have risk for certain diseases that people in Western countries might not be at risk for. Make sense? And by the way, that's a relevant category because it's people, obviously, who do come from other countries. So it is clinically relevant. If not caused by mumps virus, then the bacterial causes are same as epididymitis and prostatitis for young versus old, that i.e. STIs versus E. coli, respectively. Priapism, erection lasting longer than 4 hours, can be caused by sickle cell or by PDE5 inhibitors like tadalafil or sildenafil. Injection of alpha-1 agonists like phenylephrine into the erectile tissue is the treatment. This leads to a decreased blood flow due to the blood vessel constriction. Hydrocele. Hydrocele is the serous fluid collection within the scrotum between the layers of tunica vaginalis surrounding the testis. Mechanisms is patent processus vaginalis. Okay. The processus vaginalis, which now is spelled with a U, which is probably more accurate, I would assume. The processus vaginalis is an embryonic outpouching of the peritoneum that descends into the scrotum. It normally obliterates shortly after birth, but it remains open and can cause hydrocele or indirect inguinal hernia. Transilluminates when the light is shown on it. USMLE wants you to no treatment before the age of 1. Really? Most spontaneously close. Okay. What about a spermatocele? Spermatocele, obscure serous fluid collection within the epididymis containing sperm. Occurs usually in adult men rather than neonates as with hydrocele. Transilluminates similar to hydrocele, but again, it's an older adult, not a neonate. Varicocele, dilation and congestion of pampiniform venous plexus draining the scrotum. It does not transilluminate, in contrast to hydrocele and spermatoceles. It can be described as buzzy bag of worms. Sounds too easy, but an MVME question literally uses colloquialism. Okay. Can also be described as a heavy dragging scrotum lower on the left. Occurs almost always on the left side due to the anatomy of the venous drainage of the testis. On the left, we have a left testicular vein, left renal vein, IVC, inferior vena cava. So again, left testicular vein goes to left renal vein, which goes to IVC. On the right, we have a right testicular vein, which goes to the IVC directly, right to IVC. The testicular vein drains at the 90-degree angle into the left renal vein, creating a proclivity for hydrostatic pressure to back up ipsilaterally. There's a 2CK NBME question where the bilateral varicocele is the answer. Highly obscure, but just be aware it's somehow possible / exists. At least as far as the NBME is concerned, I suppose. It exists in the world of questions, I suppose. Can occur due to the left renal vein thrombosis and setting of nephrotic syndrome, loss of empty thrombin 3 in the urine leading to hypercoagulable state. Testicular cancer. Seminoma most likely in teens and older. Yolk sac tumors most likely in school-age kids and younger. Hard nodule on testes is buzzy, but be aware of the differential diagnosis for non-transilluminating testicular mass that does not present as a classic hard nodule. Ovarian neoplasms. Serous cystadenoma. So for that, has fallopian tube-like epithelium, can occur bilaterally, benign. Serous Cystadenocarcinoma can have psammoma bodies, 20 to 30% bilateral at time of diagnosis. Malignant, that is to say, has metastatic potential. I discussed tumor nomenclature in detail in my high-yield path PDF. Mucinous cystadenoma has intestine-like epithelium. Loculated or locular, meaning has tiny cavities like honeycomb, benign. Mucinous cystadenocarcinoma, same as mucinous cystadenoma, but it's malignant, can cause pseudomyxoma peritonei, which is the accumulation of mucin-producing tumor cells and gelatinous ascites in the peritoneal cavity. Dysgerminoma, seminoma equivalent in females, large uniform cells of clear cytoplasm, same as seminoma. Highly sensitive to chemo and radiotherapy, same as seminoma. Can occur idiopathically or in Turner syndrome. LDH is a tumor marker. Sertoli latex cell tumor produces androgens, can cause virilization in females. Granulosa cell tumor produces estrogen, can cause endometrial hyperplasia and an increased risk for endometrial cancer due to the unopposed estrogen. NBME question gives females with ovarian neoplasm plus elevated thickness of endometrial stripe plus vaginal bleeding, leading to answer for ovarian lesion, which leads to granulosa, which means a granulosa cell tumor. What about a yolk sac tumor, aka endodermal sinus tumor? The answer on USMLE for ovarian tumor in pediatrics, usually up to age of 3, secretes alpha-fetoprotein as a tumor marker. The Schiller-Duval bodies on histology, which resemble glomeruli. Embryonal carcinoma, aggressive and rapidly growing. Undifferentiated anaplastic cells on histology, secretes both AFP and human chorionic gonadotropin together as tumor markers. Usually occurs in adult men, but can be seen as ovarian tumor also. The key for USMLE is that its answer is if AFP, it's the answer if AFP and human chorionic gonadotropin are both high. By the way, AFP is alpha-fetoprotein. Whereas if only AFP is high, then the answer is yolk sac tumor. So if only AFP is high, it's yolk sac tumor. If both of them are high, it's embryonal carcinoma. You can also remember yolk sac tumor is kids, whereas embryonal cancer is usually adults. Brenner tumor, benign ovarian tumor that has urothelium, i.e. transitional cells, can appear tan or yellow. Struma ovarii, benign ovarian tumor that secretes thyroid hormone. Krukenberg tumor, gastric metastases to the ovaries bilaterally, has mucin-containing signet ring cells on biopsy. Spread to ovaries from the stomach is usually hematogenoous. Endometrial cancer. So endometrial cancer, highest yield point on USMLE is caused by the unopposed estrogen, usually due to anovulation/PCOS. Estrogen normally stimulates growth of endometrium. Progesterone prevents overgrowth. And in anovulation/PCOS, no corpus luteum is formed since the latter is a follicular remnant. The corpus luteum normally secretes progesterone to maintain the endometrial lining if fertilization occurs. If no corpus luteum is formed, there's no progesterone produced to balance estrogen. This leads to endometrial hyperplasia, which increases the risk of endometrial adenocarcinoma. USMLE can give an overweight female who's perimenopausal who has a breakthrough bleeding, that is to say mid-cycle bleeding, or a postmenopausal woman with any vaginal bleeding, and they want endometrial biopsy as the answer. The fact that the patient has high BMI insinuates that the anovulation/PCOS may have been part of her past, where the unopposed estrogen is part of her history. Can occur secondarily as a result of granulosa cell tumor of the ovary, as discussed above. This is a rare cause of unopposed estrogen. Can occur in women who take hormone replacement therapy, HRT, who stop taking the progesterone component mentioned in one MBME question. It can be associated with hereditary non-polyposis colorectal cancer, HNPCC, Lynch syndrome. Fibroid points. Fibroids are also known as leiomyomata, uteri, and are most common benign tumor in women. They are smooth muscle tumors of the myometrium. Stain positive for Desmond muscle marker, can appear grossly as white tumors with whorled structure, often found incidentally on ultrasound or autopsy. If fibroids are picked up incidentally on ultrasound, the answer is observe/follow up. The highest yield point for USMLE is that these are not managed almost always. There is negligible risk for progression into leiomyosarcoma, malignant version that doesn't exist on USMLE. In other words, do not choose answers like myomectomy. If a woman has bleeding due to fibroids, over-the-counter, what's the term for it? Not over-the-counter, sorry. Oral contraceptives and NSAIDs can be attempted in theory, although I have not seen USMLE assess these. Other treatments like leuprolide are also non-existent on USMLE. I'm going to take a brief break. Let us continue. Vulvovaginal lesions. Vulvovaginal carcinoma, cancer of the vagina and or vulva, almost always squamous cell carcinoma due to HPV 16 or 18, can occur rarely due to lichen sclerosis. Condylomata acuminata, aka warts caused by HPV 6 and 11, presents as a painless, skin-colored, or slightly hyperpigmented cauliflower-like popular lesions. I discuss all the STDs in more detail later. Lichen sclerosis presents as a whitish-gray, roughly irritated or scratchy patch on the vulva or perineum, thought to be caused by a mix of chronic irritation and autoimmunity, not HPV-related, characterized by atrophy, hyperkeratosis, and a band of lymphocytes in the dermis. It is not neoplasia, dysplasia, or metaplasia. USMLE wants biopsy as the next best step to rule out squamous cell carcinoma. If squamous cell carcinoma is negative and the diagnosis is lichen sclerosis, USMLE wants topical steroid as a treatment. Sarcoma botryoides, super rare. I'll phrase it like that. Rhabdomyosarcoma of the vagina, seen in pediatrics as bunches of grapes protruding from the vagina. Clear cell vaginal carcinoma, obscure cancer that occurs in women in their 30s to 50s due to diethylstilbestrol, DES exposure in their mothers while they were pregnant 30 to 50 years ago. Bartholin gland cyst shows up as a tender/painful bump at a 4 or 8 o'clock position on the vulva. If the cyst becomes infected, that is, warm and red, we call it Bartholin gland abscess. USMLE wants polymicrobial as the most likely organism. For cysts, sitz bath plus warm compresses are first treatment. For overt abscesses, drainage is the answer. Vaginal foreign body. Vignette will be a child with a foul-smelling discharge from the vagina. There will be no signs of physical trauma or lacerations, means not abuse. Sexual abuse can occur in children or elderly. I've seen both on NBME. Vignettes likes to mention lacerations. There may or may not be discharge. Cervical cancer plus pap smear screening. So squamous cell carcinoma occurs at the transitional zone between the stratified squamous ectocervix and the columnar endocervix. Caused by HPV 16 to 18, there are other strands students get pedantic about, but USMLE does not care. Can cause vaginal bleeding plus uni or bilateral hydroureter/nephrosis. Pap smears should be started at age 21. The vignette gives you a teenager who's sexually active. The answer is you get tests for STDs, but do not do a pap smear in spite of them being sexually active. Perform a pap smear between ages 21 and 65 From age 21 to 30, they are done every 3 years without HPV co-testing. From 30 to 65, the female has an option of continuing PAPs every 3 years or doing a PAP HPV co-test every 5 years. Pap smears are stopped at age 65. If the female has a history of high-grade squamous cell intraepithelial lesion (HSIL) or cervical intraepithelial neoplasia (CIN), Pap smears are continued after the age of 65. Patients who had a hysterectomy due to cervical cancer should have continued Pap smears of the vaginal cuff. Patients with hysterectomy due to the endometrial cancer do not. Patients with HIV requires 2 Pap smears in the first year following diagnosis, 6 months apart, followed by annual Pap smears thereafter. The vignette will tell you HIV patient had normal Pap smear last year, and student is like, cool, she doesn't need one for another 2 years. No, this is important. You need to know HIV patients need once a year Paps. Different situation for them. Low-grade squamous cell intraepithelial lesions, LSIL, and atypical squamous cells of undetermined significance, ASC-US, are managed with either repeat Pap smear or HPV co-testing, where the positive versus negative HPV test determines whether the colposcopy plus biopsy is performed. USMLE will not assess the algorithmic specifics. If you memorize the algorithm based on the female's age, you're wasting your time for USMLE purposes. HSIL on Pap smear is managed with immediate colposcopy plus biopsy. CIN1 is what we call SLIL. Again, SLIL is a low-grade squamous intraepithelial lesions, but yeah, CIN1 is what we call LSIL that is confirmed on colposcopy plus biopsy. CIN2/3 is what we call the HSIL that is confirmed on colposcopy plus biopsy. CIN1 has a high rate of spontaneous regression. Repeat PAPs are done in a year. CIN2 and 3 requires excisional or ablational treatment due to a higher risk of progression to invasive cervical cancer. Such treatments include LEEP, L-E-E-P, coning, cryotherapy, or laser ablation. Cone biopsy is also an answer on NBME for the next best step in patient who has a colposcopy performed for HSIL on PAP plus. The entire squamous columnar junction cannot be visualized. In other words, do a clone biopsy if colposcopy is sufficient. CIN3 is not excised/ablated during pregnancy. HPV lesions, including warts, are known to get temporarily worse during pregnancy due to relative immunosuppression. Biologic attempt to minimize attack against fetal antigens. In the postpartum period, CIN3 lesions are evaluated for signs of regression over the course of weeks. If they do not regress, they are excised, same as the non-pregnant women with CIN2 or CIN3. Cervical conditions confused with cancer. Cervical trauma will present as a vaginal bleeding in young women who usually within 12 hours of intercourse. Doesn't sound hard/dramatic, but 2CK questions can make a vignette somewhat nebulously where your second guesses, i.e., they might say that there's blood on the underwear. The key is that part of the history will mention postcoital bleeding. Cervical polyp, benign, non-cancerous, pedunculated tumor that grows typically on the ectocervix. It's idiopathic, can cause metorrhagia, mid-cycle bleeding, will not be described as ulcerated. If they say ulcerated, think cervical squamous cell carcinomas. That's a different thing than the polyp. Breast neoplasia plus high yield points. DCIS. Most common malignant, i.e., has metastatic potential breast cancer. Microcalcifications and mammography equals DCIS till proven otherwise. 2CK wants needle-guided open biopsy as the next best step. FNA is wrong. Paget disease of the breast looks like a nipple with eczema in patient over 50 is often a cutaneous extension of the underlying DCIS. And can I see something quickly? It says DCIS, ductal cell. Okay. DCIS breast. It says ductal carcinoma in situ. So ductal carcinoma in situ. Okay, that's DCIS. What about invasive ductal? Invasive form of ductal carcinoma, cells on biopsy have stellate morphology. What about LCIS? Same as DCIS. Again, that's ductal carcinoma in situ. What does it say? This is the same as DCIS, but malignant potential, but not yet invaded. Appears as a linear grows of cells Indian file on histome. This is supposedly due to the decrease in E-cadherin expression, where the cells don't clump together the same way they do for ductal carcinomas. I have not seen USMLE care about this detail, but I'm mentioning it here because if you ever talk to an attending about breast cancers, they become like hysterical over this detail. That's LCIS, and that means apparently. Let me look it up briefly. I'm not on my A game for this stuff. LCIS means lobular carcinoma in situ. What about invasive lobular? Well, so yeah, okay. Invasive lobular, invasive form of lobular carcinoma. So we just talked about LCIS, lobular carcinoma in situ, but invasive lobular is the invasive form of lobular carcinoma, 20-30% bilateral. Just like we had invasive ductal is invasive form of ductal carcinoma in situ. It's not like ductal carcinoma in situ, but now it's invasive rather than being in situ. What about intraductal papilloma? Unilateral bloody / rusty nipple discharge equals intraductal papilloma till proven otherwise. Inflammatory carcinoma can appear as a red inflamed breast as though there's an infection, rubor, redness, dolor, pain, tumor, swelling, calor, heat. Peau d'orange is an orange peel appearing texture of the breast due to the tethering of the skin by Cooper's ligaments and the setting of blockage of lymphatic drainage by tumor cells. I'm going to take another break again. Let us proceed forth. Chlamydocarcinoma. Cancer with a cheese-like consistency, non-existent on USMLE. Don't think I've ever seen it assessed. Okay. Which bears in mind, why is it mentioned, right? I don't know. But they probably have some students complaining about it. I guess that's the idea. Medullary carcinoma. Another nonsense/garbage diagnosis in USMLE. Mentioning comedo and medullary carcinomas because if I don't, then at some point I'll get some whiny mousy DM. Mousy, well, okay. What if the med students, mousy students, a little bit? Maybe she's cute. I don't know. Maybe don't mind that girl like that in her DMs. I don't know. From students about why I didn't mention them. Yeah. Any mousy girls want to hit me up in my DMs? You're free to do so. Okay. Fibroadenoma. Most common breast tumor overall, benign. Presents as rubbery, mobile, non-tender breast lump in women between 20s and 30s. Will appear as a solid breast mass without calcifications on ultrasound. FNA is the next best step to confirm diagnosis. If confirmed fibroadenoma, they do not need to be excised. Now, I want to make sure I'm not... Let me just confirm something. Or I should say, let me figure out something. FNA, breast. For FNA, that's going to be called a fine needle aspiration. So they use these acronyms. I'm just not as familiar with them. And I know they won't necessarily use an acronym on the actual exam. So you should need, when they say FNA, I need to know what that means. And I suspect there won't be any mousy girls on the exam either, unfortunately. Let's see. Cystosarcoma phalloides. So fast-growing breast lesion that appears leaf-like on light microscopy can be benign or malignant based on histology. BRCA points, BRCA 1 and 2, are tumor suppressor genes, but are inherited in an autosomal dominant fashion with incomplete penetrance, that is to say, sometimes can skip a generation. A pedigree requiring you to know this pattern is asked on NBME. NBME also wants you to know that with BRCA mutations, a molecular process that's messed up is a recombinational double-stranded DNA repair. Screening / MX points. Is that missing points? Is it MX? Let me just... Sorry, but this is a... I need to know. MX is short for... Oh my gosh. Mix is a English language neologistic honorific that does not indicate gender. Well, I don't think that's the intention of the person writing this. Short for medical abbreviation. I would assume it's missing. It's not a standard medical abbreviation. Well, thank you for using non-standard medical abbreviations, I guess. I don't know. Screening / maybe it's supposed to be a DX, like diagnosis points. Let me just assume it's DX. Even though D and M are nowhere near on the same places on the keyboard, whatever. For USMLE, mammography is done every 2 years between the ages of 50 and 74. Since committees / cancer task forces have varying recommendations, the USMLE does not play trivia as far as, oh my gosh, do we start at 45 versus 50, etc.? They won't be borderline about it. They'll ask you the patient who's, for example, 56, who needs a mammogram since he hasn't had one for 2 years. She hasn't had one for 2 years. If the first degree family member, i.e. parent or sibling, has a history of breast cancer, then start mammography at the age of 40 and not 50. Any breast screening done for a woman under the age of 30 do not do mammography on USMLE. Ultrasound is typically done. This is because younger women have a denser breast tissue, making mammography less specific, i.e. more false positives, and hence less reliable of a diagnostic modality. Estrogen and progesterone receptor, ER/PR, positivity is correlated with better prognosis for breast cancers. This is partially because SERMs and aromatase inhibitors can be used as treatment. HER2/neu positivity is correlated with worse prognosis. Trastuzumab Herceptin can be used to target HER2/neu. Triple negative ERPR HER2/neu is associated with bad prognosis due to the elevation in aggressiveness, increased rates of recurrence, and an elevated risk of metastasis to lung/brain. 2CK NBME wants bilateral mastectomy plus oophorectomy in patients who has confirmed BRCA mutation. Well, that's pretty severe. Breast cancer risk is elevated as a result of HRT, even when the progesterone is given as a part of it. Breast cancer risk is elevated as a result of the increase in absolute estrogen exposure the female has in her life. This has nothing to do with unopposed estrogen, which is a major risk factor for endometrial cancer. Combined oral contraceptives have been suggested in some literature as elevating the risk of breast cancer, but there's no significance. Oh, okay, so now all of a sudden when we say, oh, well, what about estrogen, just absolute estrogen increasing, even if it's combined with progesterone, doesn't prevent breast cancer from increasing in risk. Well, okay, so what about, just giving them literally estrogen from birth control? Oh, well, there's no proof of that would cause it. Like, okay, well, then either you have a dilemma. Either the estrogen itself causes it necessarily, or it doesn't, right? Because you can't eat your cake and have it too. You kind of have to say, well, in principle it should, or maybe the position that it does in principle is not necessarily true, and it's more convoluted and nuanced or whatever, But because in theory, if oral contraceptives use estrogen and progesterone combination, which they do, they would, for whatever reason you're using them. If you're trying to contracept, which I disavow, I don't think you should be doing that, but whatever. I shouldn't say whatever, but if you were, or you're using it because of some sort of hormonal issue or whatever, regardless, it should in principle, if it has elevated estrogen, increase the risk. Now, he's saying there's no significance to it. That might be true, but that should bring us back to the question of, does estrogen necessarily increase risk for breast cancer? Which he also maintains to be true as well, which is, again, presents a little bit of a dilemma, you could say. Now, there used to be, I believe, oral contraceptives which basically had very little to no progesterone in them. I think they would not have a progesterone element to them. And the reason why they took those off the market is because they elevated the risk of certain kinds of cancers in a way but progesterone had a protective effect in these cases when it's added together to kind of mess with that risk factor, if my memory serves correctly. As I talked about before, the reason they only approved indication HRT is a... Where were we? They won't assess this on USMLE either way, but they do assess elevated breast cancer risk as a result of HRT. So if you take HRT, they say, oh, breast cancer, that kind of thing. As I talked about before, the reason they only approved the indication of HRT is severe vasomotor symptoms, i.e. not to maintain bone density, etc., is because HRT elevates the risk of breast cancer, thromboembolic events, MI, and stroke. This is because estrogen upregulates fibrinogen and factors 5 and factors 8. Where are we now in terms of time? Okay. So, other breast conditions. Fibrocystic change, benign cystic alterations in breast tissue in women between 20s and 50s, shows up in three ways on MBMEs. Highly buzzy/classic presentation is a woman in her 20s or 30s who has a bilateral waxing/waning breast tenderness over the course of her menstrual cycle. Unilateral tenderness or sharp pain in one breast. Students are often surprised that it's not always bilateral. Painless unilateral breast cyst in woman over in her 40s that drains brown/greenish fluid. That sounds pretty crazy. Answer equals fibrocystic change straight up on MBME. Call it weird all you want. Take it up with MBME, not me. You do not need to biopsy or do ultrasound. It is clinical diagnosis and treatment is symptomatic only, i.e. warm showers, evening primrose oil. In theory, biopsy of fibrocystic changes will show some buzzy findings like sclerosing adenosis, apocrine metaplasia, and or blue dome cysts. Simple breast cyst. Simple means hypoechoic or black on ultrasound. It reflects a fluid-filled cyst. Complex means at least in some part of hyperechoic or white on ultrasound. It reflects a solid component to the cyst. Simple cysts are observed and do not require FNA, again that's fine needle aspiration drainage, unless they cause discomfort to the patient, i.e., or that's to say like large cysts. There is no specific size that requires drainage on USMLE. There is an NBME question where they say a woman was started on HRT 3 months ago and now has a simple cyst. The answer should be biopsy of the lesion. So you should be aware that the sudden growth in size can be indication for biopsy. All complex cysts require fine needle aspiration biopsy, similar to fibroadenoma. Mastitis classically presents as a red, cracked, fissured nipple in breastfeeding woman, usually caused by Staph aureus, but group A strep is also possible. USMLE wants oral decloxacillin, not doxycycline, plus continuing breastfeeding. Though the affected breast has treatment, there is no risk of harm to the neonate. Methicillin class beta lactams, that is to say, like decloxacillin, and first generation cephalosporins, like for example cephalexin, are equivalent on USMLE for all interests and purposes. They both treat Staph aureus skin infections. High yield point is that the mastitis need not affect the nipple and can present as a red, warm, tender, non-fluctuant mass of the breast. When we talk about infection of the breast, non-fluctuant means mastitis, fluctuant means abscess. This is asked insidiously on a 2CK form, and students get it wrong all the time because it's abscess, i.e. they say it's warm, red, tender mass of the breast though. Yeah, but they say it's non-fluctuant, and that is to say not fluctuant. Not my issue if they get emotional over this dumb stuff. Remember, non-fluctuant means mastitis, fluctuant means abscess. Abscess, warm, red, tender, fluctuant mass of the breast. Drain as the next best step. Galactocele, aka milk retention cyst, usually seen in recently breastfeeding women, often confused with breast abscess, can present as a painless or tender fluctuant mass on the breast that is periareolar. USMLE will say that the patient is afebrile and that the lesion is not warm or red. Treatment with warm compresses followed by drainage. Ductal ectasia. As the name implies, this is dilation of the lactiferous ducts. Diagnosis of exclusion on USMLE, i.e. we eliminate to get there, presents as a 2/3 questions on an inverted nipple. Presents 1/3 of questions as some random breast lesion where they say biopsy shows dilation of the ducts, which is what the name means, ductal ectasia. Virginal breast hypertrophy. Virginal breast hypertrophy is benign asymmetric growth of the breast that can occur in young women. USMLE will try to trick you into thinking it's sinister by saying a first-degree relative had breast cancer. They will say that a 16-year-old has a large breast lump under the nipple on one side. Answer is just follow-up/observe. Well, that's kind of confusing, potentially. Okay. Gynecomastia. Physiologic gynecomastia can occur in teenage boys in USMLE where they can have elevated breast tissue, either increased breast tissue, either tender or not, occurring uni or bilaterally, just observe. Can occur as a result of elevated estrogen and liver failure or due to certain drugs like cimetidine, spironolactone, ketoconazole, or even marijuana. Caused by direct estrogen effect on breasts, it is not caused by prolactin. As I talked about earlier on NBME, question gives a gynecomastia in a male patient taking a human chorionic gonadotropin. They ask for the mechanism. The answer should be testis producing estrogen. They can also have an answer, estrogen, direct effect on breast. The reason this makes sense is because since human chorionic gonadotropin shares the same alpha subunit with LH and FSH and TSH, giving human chorionic gonadotropin is as though we are giving LH and FSH at the same time. So LH effect means androgen production, FSH effect means aromatase production. Therefore, androgens are converted to estrogens in this testis, means mechanism via which we could get gynecomastia. What about necrosis? Non-enzymatic fat necrosis of breast due to the trauma can calcify. Don't confuse with enzymatic fat necrosis, which is an acute pancreatitis, can occur due to overt trauma, that is to say getting hit by a softball or sometimes by tight-fitting sports bras. Other ovarian conditions. Ruptured ovarian cyst presents as a sudden, sharp pain in an adnexa. Adnexa equals combo of fallopian tube plus ovary. The question will often say there is a 10 to 15 milliliter of serosanguineous fluid in a pouch of Douglas on coldocentesis, means the aspiration pouch of Douglas. The question will say there is no mass, such will not mention mass. Treated with symptomatically, that is to say with an NSAID, do not do laparoscopy for ruptured ovarian cyst. Adnexal ovarian torsion. Three-quarters of questions will give intermittent adnexal pain that becomes constant over the hours to weeks. I've seen NBME give both time frames. 1/4 of questions will just say a few hours history of constant pain without intermittent for detail first. Presents as a large adnexal mass, that is to say 8 to 12 centimeters. There is no mention of fluid in pouch of Douglas. Treatment is a laparoscopic detorsion. Tricky detail is that the biggest risk factor is pre-existing anatomic abnormality, like a cyst. So if they say history of cyst plus now has a large adnexal mass and pain, that is a torsion, not a ruptured cyst. Theca lutein cyst arises from the theca cells of the ovary, usually bilateral, frequently associated with conditions where the HCG is very high, such as moles, multiple gestation pregnancies, or fertility drug use. Can occasionally bleed, where the answer is hemorrhagic theca lutein cyst, as the diagnosis of exclusion, i.e. we eliminate to get there, where the endometrioid cyst can be eliminated because the question won't mention anything about dysmenorrhea or signs of endometriosis. Endometrioid cyst, aka endometrioma, or chocolate cyst, can be cysts filled with endometrial tissue that bleeds, occurs in endometriosis, endometrial tissue growing outside the myometrium, usually on the ovary, as with this case discussed more later. Dermoid cyst, aka cystic teratoma, contains tissue of multiple germ layers, i.e. hair, skin, teeth, etc. It can calcify. What about testicular cancer? Seminoma, most common testicular cancer, occurs in teenage years and older. Large uniform cells with watery cytoplasm, chemo and radiosensitive, place the ALP and can be a tumor marker. Yolk sac tumor, aka endodermal sinus tumor, most common in kids under the age of 3. Alpha-fetoprotein is tumor marker. Embryonocarcinoma, immature/anaplastic cells, combined alpha-fetoprotein and human chorionic gonadotropin are tumor markers, usually adult men. Sertoli-Leydig cell tumor secretes androgens, can cause gynecomastia, shows up on NBME. This is because the elevated androgens can be aromatized into estrogens. Granulosa cell tumor secretes estrogen, can also cause gynecomastia. If NBME gives you a question with Sertoli-Leydig cell tumor causing gynecomastia, they won't simultaneously list granulosa cell tumor as an answer. Choriocarcinoma, composed of syncytiotrophoblastic placental cells, can occur in males, yes, usually 20s to 30s. Significantly increased HCG as a tumor marker. Where are we now in terms of time? I'm going to take another break. Okay, let us proceed forth. Now, where were we? Prostate cancer versus BPH points. Prostate cancer, adenocarcinoma, i.e. glandular, most common cancer in men, stimulated by DHT, causes osteoblastic metastases. High yield point on USMLE, can present as a random guy over the age of 50 with no past medical history, who just suddenly has neurologic symptoms in the legs, and 2 blastic lesions in his spine picked up on MRI. If neuro symptoms are present due to spinal metastases, give IV methylprednisone. If no neuro symptoms are present and they just say vertebroblastic lesions, answer will be radiotherapy. I've seen distractor answers in this case, such as morphine plus corticosteroids, where the student says, I thought we give steroids though. Yeah, if the patient has a neuro symptom, which he does not have here. Plus, jumping into morphine before trying other pain meds first is wrong anyways. Orchiectomy will decrease androgen production. This will lead to atrophy and shrinkage of the prostatic cancer cells. Flutamide blocks androgen receptor. It is given prior to leuprolide, which is a gonadotropin-releasing hormone receptor agonist that, when given continuously, causes desensitization at gonadotropin-releasing hormone receptor. Since leuprolide can increase the LH and FSH prior to desensitization, the flutamide is given first. Prostate-specific antigen PSA will often be elevated. Free PSA, that is to say, not bound to protein, is low compared to bound PSA in prostate cancer. Gleason scoring is used to grade prostate cancer. The parasympathetic nerves for erection are at greatest risk for injury during radical prostatectomy, as somewhere on NBMEs. What about BPH? BPH, or benign prostatic hyperplasia, all old dudes have enlarged prostates due to lifetime exposure to DHT, which causes the prostatic enlargement. Let's just say, what is DHT? I know what it is, but I forgot what the actual letters stand for, technically speaking. And let's see, it's like dihydrotestosterone or something like that. What is it called? It is dihydrotestosterone. Okay, so it's called dihydrotestosterone, DHT. But that can cause prostate enlargement over time. Present as a dribbling hesitancy commencing urination or interrupted stream in males over the age of 60, but usually 70s plus. Old dude plus high creatinine equals BPH till proven otherwise. Discontinue anticholinergic medications because they cause urinary retention. This concept shows up a lot on NBMEs. 3 classes of drugs in particular: first-gen H1 blockers, histamine 1 blockers, like diphenhydramine and chlorpheniramine. And then you have tricyclic antidepressants like amitriptyline, and you also have antipsychotics. So you'll get the question where an older male has a high creatinine, and then the answer is just discontinue anticholinergic medications or discontinue the diphenhydramine. Can be described as a nodular on palpation. Prostatic-specific antigen PSA will be elevated. Free PSA is high compared to the bound PSA in BPH. The treatment would be an alpha-1 blocker such as a tamsulosin or terazosin or the 5-alpha reductase inhibitor finasteride. Transurethral resection of prostate, TURP, for refractory cases. And so now we're going to go into STDs. If we wanted to, high-yield STDs. We're on page 189. We started on page 181 or 180, something like that. We have another 20-plus pages to do, but I actually want to cut the video at this point. I'll probably begin again tomorrow, I would assume, and get the last maybe 2 hours worth of content at that point, either as 1 or 2 videos. But anyway, if you like this video, hopefully it was a good use to you. Regardless, have a great rest of your night. Thank you, and goodbye.